Good morning, good afternoon. Very excited for yet another version of RLR that'll be familiar in many ways and a return to the glorious days in others. The familiarity is because I think our most regular RLR case presenter, Zakaria G, the OG, is here with a case. Let me hand the mic to you to say hello.
Hi everyone, my name is Zakaria G, and South Africa. Yeah, it's one of many ICU cases that I have with a bit of a twist, and I'm really excited for it.
Well, amazing. Yeah, I think the twist will be, I don't know if I believe you, it's a little bit of a twist, but excited to go on the journey with you. Your namesake, which necessitates the use of your last initial, is also here, Zachariah E. I'll hand the mic to you. Thank you for scribing today.
Hi everyone, I'm Zakaria E. Although Zakaria G prefers to be termed the OG, I'm here to stay.
Yes, the punching gloves are still on for different reasons. I love it. I love it. And now the return to very, very familiar distant memories of CP solvers in return. We have our beloved Harry Chung here doing teaching points. Harry, mic to you, my friend, and maybe you can update folks on your life.
Hi, everyone. Yeah, I've been a little absent. I finished residency and started chief year, so doing a little bit of different clinical thing, less clinical things and more emails and administrative things and reports. But things are settling down and happy to be here and start getting back into CP solver stuff.
We're thrilled to have you. Excited that you'll have to capture the wisdom today. It'll be a lot when Zachariah G is presenting to us. We also have our beloved Bettina here. And I had no prompting for Bettina, but Bettina is one of our CRC leaders who is working very, very hard to make it easier for all of you to present your cases. Bettina, can I hand the mic to you just for folks to be familiar with your voice, owing to the all incredible work you do behind the scenes?
Yeah, hi everyone. So nice to see you all. Just wanted to take this opportunity to plug, please submit cases to the case review committee. So you're gonna see a QR code later on the whiteboard. So please come check it out and submit a case with us.
We have so many people following in the legacy of the innovative Prof. Rez who are all doing small and large innovative things, including having the QR code right there for you. Oh my gosh, how easy it is to submit a case for Prof. Rez to dissect. And I'm saying his name over and over again to jolt him into popping on. And here he is. Hello, Prof. Rez. We have summoned you.
Good morning, good morning, good morning. How are you?
I'm doing really well, Prof. Rez. There's so much active medicine on my team right now. We have 14
Really?
patients, and 0 of them are placement patients. All 14 of them have something going on. And so I'm ready for another patient, Zacharias, today. Apparently, another ICU case with a twist. And so I'm already going to say the diagnosis is dermatomyositis complicated by syphilis, complicated by lymphoma, complicated by hyponatremia, hypercalcemia. Prof. Rez, how are you?
I'm doing really well, man. Just hanging out, finishing up med consult, getting ready for my trip to DC early next week.
Yes.
So looking forward to it. Looking forward to discussing with you today.
Awesome. Awesome. All right, Prof. Rez, let's rock and roll. Zachariah, mic to you, my friend, and we'll hear some Prof. Rez thinking right after you're done.
Okay, hi everyone. I'm very excited for this case, and I think the first twist is that I actually lied. It's not one patient. I'm going to continue a trend, and it's actually 2 patients. Only one of them was in the ICU, though. So the case title is A Tale of 2 Teenagers, and this is the story of 2 teenagers that I have seen this year, who both had the chief concern of altered mental status and abnormal movements. And what I did to make it a little bit easier to follow is that I've given both of the patients different names of famous South Africans, just to make it a little bit easier to follow. So patient Nelson is a 15-year-old male, and about 24 hours prior, he had been completely well. He then started behaving strangely, was not speaking, and his sister brought him into the hospital, who reported that he'd been completely well and he had no known past medical illnesses and had no substance use. And then patient Desmond is a 19-year-old male who about 1 week prior had been brought in by emergency services after he'd been found unconscious. He came into the emergency room.
Zachary, I'm so sorry to interrupt you. Just so that, can you be mindful of the whiteboard, just so that the other Zachariah can keep up with what you're saying, so that we can have it all there?
Absolutely.
If you don't mind just summarizing case one so Zachariah can catch up. Appreciate it.
I'll move a little bit slower. Yeah, so patient Nelson was 15, and about 24 hours prior, he'd been completely well. And then his sister brought him in as he'd suddenly started to behave strangely, was not speaking, and she reported that he'd been completely well the day before, and he'd had no history of any substance use and had no past medical illnesses. And then patient 2, who I've named Desmond, had been brought in about 1 week prior by emergency services. He'd been found unconscious at home, brought into the emergency room, and was subsequently intubated, as he was unfortunately not protecting his airway and had respiratory distress. He then extubated, and we then noticed that he started to become agitated, restless, also would not speak. And in addition, he showed abnormal movements involving both his arms and legs, not associated with any loss of consciousness. I'll put that in the chat as well.
All right, well, that's a great start. Interesting title to today's VMR. And maybe I'll just share my general thoughts and then have Robbie layer upon those. I think it would be a mistake to get too specific here. Right now, what we have is altered behavior in patient A, and then decreased consciousness in patient 2 or patient B. I think what we really need to do here is establish a time course. And once we establish the time course, then we can start prioritizing broad categories in the differential diagnosis. And for patient A, the time course would be acute because it's within 24 hours. Hyperacute would be within seconds to minutes. And sometimes it's difficult to really confidently label the time course, especially in the case of altered behavior or decreased consciousness, unless someone is accompanying the patient that can provide a detailed and accurate history. But regardless of whether someone is with the patient or not, I think for the acute altered mental status, for patient A, just think of 3 overlapping Venn diagrams, and they will apply to patient B as well. You have your psych, your neuro, and your medicine. And in the medicine category is the mismnemonic, and the things that get prioritized at time point 0 is going to be the metabolic stuff and the toxic stuff. And metabolic, just think of your fishbone diagram, and anything from low glucose to low sodium to high creatinine and uremia can lead to altered behavior. But then there's other substances that you need to be aware of, other electrolytes like ammonia, carbon dioxide. And it must be said that this patient is so young and has so much reserve that this is a huge delta from their usual baseline. And then, of course, it's not enough for someone to say they don't have substance. You're going to get a urine tox, and you're going to want to know the past medical history to know if the substance is off or too much of a substance is on. I really think the toxic metabolic stuff is prioritized in the medicine realm. And then there's obviously psychiatric disorders and neurologic disorders. In patient 2, who's found unconscious, I'm sorry, the whiteboard is a bit blurry. In patient 2 who's found unconscious, it's really the same approach. If there's abnormal behavior, abnormal movement too, you would have to really entertain the idea of seizure. But seizure is usually not an end diagnosis, and there's usually a culprit to what's driving the seizure if it's not epilepsy. But that's all I have to say. I'm going to pass the mic to Robbie to layer upon those two. I think we're still very broad, and it can be anything, but I think the general theme is it a medicine, is it a neuro, or is it a psych-related process?
Yeah, 100%, Prof. Rez. I'm right there with you, and I think that one interesting exercise you can do to see what Prof. Rez just taught you in another supplementary angle is to ask yourself, if you could do a brain transplant, what would happen? That seems like a preposterous question, but it's a good thought experiment. So what we're going to try to figure out for Mr. Nelson and Mr. Desmond is if we take their brains and put them in somebody else's body, will they wake up or not? And if Mr. Nelson wakes up, then we know that there's nothing wrong with his brain. It's something wrong with the blood that's percolating in his brain, and the same is true for Mr. Desmond. But if you were to do a brain transplant on both of them and they still remain sleepy, even though you've optimized the perfusion in their blood, you know that actually there's a blood problem. So it's a very sort of simple thought experiment. And that thought experiment can help you figure out, is it an actual intrinsic brain issue, or is it a problem of what the brain is bathed in? And what the brain is bathed in is often the problem. And so hypothetically, if you could do a brain transplant, both of these patients would wake up. And the question becomes, is it a problem of the blood quantitatively, meaning there's not enough blood making it into the brain, and that's a code blue? Or is it a problem with something in the blood that is making the brain unhappy, be it a toxin, an infection, so on and so forth? So I think it's interesting to say, well, what progress can you make about that hypothetical brain transplant disease? And I think that it's a very simple premise. The blood that's making the brain unhappy doesn't just percolate in the brain alone, it percolates in the other organs. And so often other organs are also unhappy when there's a blood problem. And so I think that's what we'll do. Right now, Zakaria has forced us to zoom in on the brain, which based on the patient's severity is very high. The question is, what's happening everywhere else? And if there's problems everywhere else, it's more likely to be a blood problem. And if there's no problems elsewhere, it's more likely to be a brain problem. And I think that's the inventory that Prof. Rez zoomed in on, and that's what we'll do for the rest of this time and try to figure out where the lesion is. Very simple. Is it brain or is it the blood? And we'll see. And about when Zakaria hears the final diagnosis, tells us the final diagnosis, we'll replay the brain transplant hypothetical and see where that takes us. All right. Mike to you, Zakaria.
I've never heard that before. And that's something to definitely remember. I think starting with patient Nelson, the 15-year-old, he was mildly tachycardic, but blood pressures were normal. He had a temperature of 36 degrees and a capillary refill time of 4 to 5 seconds. He appeared dazed, confused, didn't answer questions or understand anything when I spoke to him, and he had bilaterally constricted pupils. However, his respiratory exam, he had a normal respiratory rate and he wasn't in any distress. He was quite agitated and I had to ask security to restrain him while I took blood. And just as I was about to start, he actually lost consciousness for about 30 seconds, and associated with that had some light hand twitching. So that's his exam. Patient Desmond, so there's two parts of this exam. The first part of the exam is the week prior when he'd been admitted to the emergency room. He came in also mildly tachycardic with normal blood pressures, was afebrile, but he had respiratory distress. On examination, had bilateral crackles, and he had an oxygen saturation of 71% on room air. Then on to his neurological exam. This is 1 week later, once we'd extubated him. This again, he was confused, agitated, wouldn't speak when you spoke to him, and he had these abnormal movements involving both his hands and his legs that were sudden, jerky, would then stop, and that was it. He had no loss of consciousness or any other abnormalities on neurological exam. And I'll stop there.
Prof. Rez, how about I analyze Mr. Nelson and you analyze Mr. Desmond? How does that sound? All right, man. So, Zakaria, I actually got a phone call from my resident who's dealing with a bradycardic code in the middle of your outlining that exam. And what I gathered was that the specific features we found was that he has bilateral meiosis or constricted pupils. And then I heard you say something else of relevance, but I forget what that was. I don't see it on the whiteboard. I want to make sure I didn't miss it.
So bilaterally constricted pupils at a normal respiratory rate of about 18 and low respiratory distress.
Gotcha. So essentially, everything else is a pertinent negative, and the pertinent positive is that his pupils are constricted. Is that a fair summary?
And then just to add, I'm not sure if you heard, while I was starting the exam, I started to take, and he suddenly lost consciousness and had a 30-second episode of his right hand shaking.
I see. Oh, that's very, very helpful. Yeah, thank you for that. I remember you saying something of interest, but I wasn't able to upload it in real time. And I think that observation is incredibly powerful. But let's take the first observation, which is that you haven't mentioned anything outside the brain yet. So I think if we're figuring out the brain and blood tension, there seems to be more and more brain action and less blood action. And the blood action could have been that you said he's febrile, he's hypotensive, he's tachypnic, and so there's not much blood action here. So what is the brain action? So we're seeing that the bilateral pupils are constricted, which means that the bilateral pupils are getting too much parasympathetic input. They're tiny. You could also come to the conclusion that there's been bilateral sympathetic loss or bilateral parasympathetic excess. And in general, when both pupils are behaving the same way, it's much more likely that there is an excess problem rather than a deficiency problem. So a deficiency problem, i.e. sympathetic loss, i.e. Horner syndrome, is often unilateral. It's much easier to have a substance in excess, like a cholinergic substance, constricting both pupils, than it is to have a deficiency in the entire sympathetic system affecting both sides. So as a general rule of thumb, we talked about this yesterday, whenever you have bilateral pupillary abnormalities, it's often a syndrome of that aspect of the autonomic, parasympathetic or sympathetic, in excess. So I could conclude there is bilateral sympathetic deficiency, but I think it's more likely that there's bilateral parasympathetic excess. And now, why would there be bilateral parasympathetic excess? The most morbid hypothesis are substances that trigger it, namely opiates and hypercarbia. Remember that, it's called CO2 narcosis for a reason, because it mimics the action of narcotics. And so my no-miss substances that are in excess are opiates and carbon dioxide. And then I would only think about parasympathetic excess outside of those two things, in large part because the patient doesn't seem to have evidence of parasympathetic excess elsewhere, meaning that instead of him being bradycardic on his vital signs, he's tachycardic. So he not only seems to have parasympathetic excess, he seems to have that excess localized to his nervous system, which is a further hint towards the possibility of CO2 narcosis or opiates. The other variable that you have shared with us, Zakaria, is very, very powerful, because you have loss of consciousnness and right hand twitching, and that is very, very concerning for the possibility that the patient has a seizure. And the seizure seems to have some focality to it, so the contralateral cortical space seems to be implicated in this disease process. And so it's an interesting combination of things here. You have what appears to be a diffuse process based on the fact that both pupils are constricted, but there is a hint of focality with the fact that there is right hand twitching, implying the left cortical spaces impacted. So if I'm trying to visualize this brain, I have reasons to think that everything is impaired based on the fact that he's lost consciousness and that both pupils are tiny. But we also have reason to highlight beyond the baseline disease everywhere in the brain, a specific part of the brain. And here's the simple question. Did that specific part of his brain that is an extra highlight cause a whole brain phenomenon, i.e., is he have some disease focally in that left space, and because of mass effect or seizure or something, that focality is radiating and causing chaos in the rest of the brain? Or does he have intrinsic disease in the rest of the brain independent of that focality? And so what could be happening? He has multifocal brain masses, and one of them is particularly symptomatic and the rest are causing a diffuse loss in sensorium. Or that focality is radiating its effects to the rest of the brain through pressure, like cerebral edema, hemorrhage, or through its impetus for electroactivity. So This is the tension when you have a diffuse and a focal problem. Is the focal problem a clue there is a multifocal problem? Or is the focal problem the source of the diffuse nature through pressure or electricity? And I think that's the tension that I'm grappling with. Prof. Rez, pass the mic on to you. Anything you want to clarify for Mr. Nelson? And,
That's great.
Prof. Liz, sorry to interrupt, can I ask that before you go into the exam of Mr. Desmond, there's actually a video of a similar patient with a similar kind of abnormal movements that I think is really powerful to show.
I'd love to see, but Zachary, can I ask you one question? The oxygen went from 71% to what? On the board, I'm not sure what that.
Sure. So we'll come to what happened with his saturations later, but the week prior, before he'd been admitted to ICU, when he came in with the EC, he'd been not protecting his airway, had bilateral crackles, and had an oxygen saturation of 71% on room air. And then he subsequently recovered about a week later. But we're going more into SATs in the next. This is a similar patient, or I think somebody just demonstrating what my patient had. Yeah, and I think that's pretty much it. But the only thing I'll say is that it was bilateral, so both his hands and legs at different times.
Yeah, I'd say that the beauty of that video is it illustrates that it's not a chaotic movement like a seizure would be. It's an organized, smooth movement on the spectrum of chorea or athetosis. And so that changes the localization for me. It makes the localization a little bit more likely to be in the deep brain structures, the basal ganglia, than it would be the cortex. So still invoking focality. But
right, I think that's patient 2 though. Right? Yeah. That's not the first patient, is it, Zachariah?
No, this is actually for you, Prof. Des. So patient.
Oh, yeah, I'm so sorry, Prof. Des.
Yeah.
Good luck to us, Prof. Des. I have no idea. I think we're just solving patient Delson at this point. They're both merged in my
mind. Yeah, so I was actually going to say it looks like that patient is dancing, and that's what chorea is, dancing-like movements. And that patient is a little different than the patient that Robbie was discussing, Nelson, because it is bilateral. So there is no vocality in terms of unilateral, which is often how we think about abnormal neurologic processes, but something that's causing abnormal bilateral movements. And I think those structures like the basal ganglia, which are involved in keeping posture, keeping things, within, without like much movement, is being irritated. And interestingly, this patient doesn't only have a neurologic problem, but has a preceding pulmonary problem, which included hypoxemia and pulmonary crackles. And this is all happening after extubation. So I think you really got to plot out the sequence of events. It would be it was almost like Zachary, the other case you presented. We started with the echo and the low EF, but that's not really where the problem started. We were actually solving the wrong problem. We focused on that, but that was just a byproduct of stress-induced cardiomyopathy. It wasn't the main problem of what was happening to the patient. And here you'd be making a mistake if you just start with the abnormal movement, because this story starts a week prior. So the abnormal movement, I would say, yeah, there's something that's irritating those deep structures that control movement, including the basal ganglia. Yes, I'm interested in an MRI with gadolinium, but more important than that is what happened before. What happened to the lungs? And for example, if someone is hypoxemic for a long period, they can have areas of the brain that suffer ischemia, and you can have sequela of that. So I'm actually not going to interpret those abnormal bilateral movements in isolation. I need to gain clarity on what happened a week prior. Otherwise, it would be a mistake. It really would. So I'm staying authentic to the case. So I'll wait for you to give us more information for that patient before interpreting the exam, knowing what had preceded the presentation.
Absolutely. Okay, so onto the initial labs of both patients. So for the 15-year-old patient Nelson, he had a white cell count of 25 that was neutrophilic, platelets of 137, and he had a very mild AKI. His HIV was negative. He had a urine tox screen positive for methadone, but nothing else. And on his venous gas, he had a lactic acidosis with a lactate of 7. This was at least an hour and a half or so after he'd had that episode of losing consciousness and right arm twitching. His CRP was 406. Then for patient Desmond, the patient who came in altered with respiratory distress, he, on his exam when being admitted to the hospital, had a PO2 of 110 on room air. And this subsequently progressively worsened, eventually requiring him to have very high FiO2s and PEEP to maintain his oxygenation. He'd had combined respiratory and metabolic acidosis with an elevated anion gap and a lactate of initial E6 that then started to decrease. And in terms of his bloods, only 3 things were really remarkable. He'd had a white cell count of 21, a CK of 6,000 on admission, and a BNP of 2,500. And his tox screen for the urine was negative.
Oh, okay, so Ravi, I'm going to stay with patient Desmond. Just so I know that you're like juggling multiple stuff with your team, so you're well aware of what's happening with Mr. Nelson. But Zachariah, was he intubated for respiratory distress? Is that what happened?
So when he'd been found at home, he'd been found down, having lost consciousness. And when he was brought into the hospital, due to his low level of consciousness and the fact that he wasn't protecting his airway and already had respiratory distress, he was intubated.
Gotcha. That's really helpful. And I think the mistake here would be trying to name a diagnosis. I'm still not sure like where the actual, like, yes, there's abnormal movement. Yes, there's stuff happening probably with the respiratory system. Yes, there's an elevated white blood cell count and the patient's inflamed, but I still don't know what problem I'm solving. Like I really do need more data. Here, the CK being 6,000 doesn't really bother me too much. This guy was found down. You don't really get sequela of rhabdomyolysis and kidney injury until the CKs are like more 10,000 or north. Of course, I would trend the CK, make sure it's not rising, but we have a really good explanation. His white count being 21,000, could he be inflamed? I think I heard his CRP was really high as well. And so I would, activate that framework for inflammation, but I'm also open to the possibility that he's under so much stress for one reason or another that he's having demargination of mature neutrophils. But I would be thinking, is there an infection somewhere that's driving this process? And could that infection be in the lung? Could it also be in the brain? And can it be throughout the entire system? With regard to his anion gap acidosis, I mean, this guy is sick. Like, you have to be cautious when you interpret stuff in patients who are in the ICU or are very sick, because a lot of times the abnormalities are a consequence of hemodynamic compromise. So the real exercise in this aliquot is trying to understand what is signal and what can help you frame the problem. I think what this aliquot does for me is just inflammation. So now infection is rising. And we already knew that he has decreased consciousness, decreased respiratory drive based on that really high PCO2. And the question then becomes, is this acute hypoxemic respiratory failure leading to hypercarbia, leading to decreased consciousness? Or is there a brain issue leading to decreased consciousness, leading to hypercarbia, etc.? Now, with the oxygenation being so high, maybe there isn't much stuff happening in the lung, but what would I do next? I mean, this guy's in an image negative state, I would definitely get blood cultures. I would have a low threshold to start empiric antibiotics, but I would want at minimum a chest X-ray and a CT of the head. So again, because like my thought process right now is a bit scattered because the information, there isn't anything that is strongly pointing me towards one direction. So lung pathology or brain pathology, inflammation most likely, more data will help us make progress.
Prof. Rez, your voice is so soothing and so clear and so calm and linear. Maybe just to remind everybody, I'll share a summary of the other patient so we can move and reframe. So Mr. Nelson is a young man who developed abrupt onset strange behavior, was found to have bilateral constricted pupils, and then appeared to have a seizure when Zachariah was taking care of him. And in him, systemically, we do have a fingerprint, though it seems to be much less angry and aggressive than Prof. Rez's very sick hypoxemic patient. It's notable, though, for the patient having a deep neutrophilic leukocytosis, a high CRP, and a very powerfully framing UTOX, positive for methadone. So I think that it's amazing how helpful the context is for when people are getting sick, and I think that here the presence of opiates explains the constricted pupils and opens us up to reasons as to why a young, otherwise healthy HIV negative person would get a syndrome like this. And I think you worry that you're now trying to figure out opiates plus altered mental status. And it becomes really, really important now to examine the patients for track marks to make sure that intravenous opiates aren't a part of this aspect, because ingested opiates in the mouth have a disproportionate brain effect, which is certainly happening in this patient, but injected opiates have a variety of other complications on the cardiovascular system, which could be spreading to the brain. And so that's probably how I would begin to frame him. But now I think that we're solving a problem of CNS catastrophe in a patient who has opiates on board, which there's a variety of things to entertain. And the question I think that remains is the systemic signature that we're getting. Is that merely just a function of the seizure activity that he just had? And it's impossible not to have a deep neutrophilia, lactate, so on and so forth in the seizure, or is it a marker that there's something else going on in the blood itself? So I think, like Prof. Rez said for his patient, Mr. Nelson also has an imaging deficiency to figure out, does he have something in his lungs, in his belly, and his brain, or is it just in his brain? And if we're trying to visualize his brain, we know his brain is diffusely down, but let's remember that in him, unlike Prof. Rez's patient, he has an asymmetric focus of activity. And so the probability that he has a true intrinsic brain problem is much higher based on that locality. All right, Mike to you, Zachariah.
Absolutely amazing. Okay, so I think the first thing is, Rabih, I'm going to answer your question and give you the imaging that you want.
Wow, look at that, Prof. Rez. He's being kind, finally. Wow, how generous.
Let's see if that holds up to be true. So this is
I don't think it will.
Yeah, so this is the CT brain of Mr. Nelson, the 15-year-old male. So that's the CT brain. And I'll let you hold your thoughts, if you don't mind, for a second, while I share the X-ray on admission for Prof. Reza's patient.
Prof, this isn't fair. I have to interpret a brain CT and you interpret an X-ray?
Yeah, and that's the X-ray. Yeah.
Zachary, do you want me to interpret this while the X-ray's up to give Rabih a minute to think about that CT scan? You see, this is so helpful, right? And before you rush to interpret this chest X-ray, you're going to want to know what was his chest X-ray a week prior. And Zachary, can I just ask you, was it similar to this or was it different than this?
So, so this is the X-ray when the patient was brought in by emergency services before he became to the ICU.
Gotcha. Okay, that makes sense. Gotcha. Thank you. So you see how important this is? Like you can spend hours trying to pontificate. Is it the brain? Is it the lung? Is it chorea? Is it synonyms? Is it this? Is it basal ganglia? But all you need was an X-ray. And of course, this X-ray is abnormal. Of course, you have, I mean, what's striking is the pathology in the right lung. And you can see, like, there is a clear demarcation of the upper lung from the lower. And the question becomes, is that just fluid filled with a collapsed lung? Which it very much can be, but that's not the only abnormality. You can see sort of fluffiness throughout both lungs in the upper field. That's abnormal. The costophrenic angle on the left is great. The costophrenic angle on the right is undetectable. So what I would say, it looks like we have a pleural parenchymal disease entity that is involving both lungs, not just the right. And when you see white, it's a very simple exercise of, is it pus? Is it water? Is it red blood cells? Now we have to incorporate the other data that the patient has. They have a leukocytosis, neutrophil predominant, a really high CRP, and we had activated our inflammation schema. So, and it's a young person with no history of heart disease. So really you're prioritizing exudative processes. And when you do that, you just have to use the IMA mnemonic. And in this patient, I would prioritize infection. And so what I would do next is I would put this person on broad spectrum antibiotics. It would include vancomycin and atypical coverage. I would also do an ultrasound. To be quite frank, I would get a CT scan. Just, it gives you so much more data because I need to know, it seems like there's enough pleural effusion to do a thoracentesis and the patient should have that done. But now all of a sudden, what this X-ray does for me, whatever the final interpretation of this X-ray is that I know there's pulmonary pathology that must be explained by the final diagnosis. I know there's significant inflammation. And the question then becomes, is the brain stuff just secondary to the sequela of acute hypoxemic respiratory failure and decreased consciousness and sequela? Or is there a long brain disease process through a hematogenous spread? So next steps, CT scan if possible, or a quick ultrasound, empiric antibiotics for CAP, but covering all types of organisms, and CT head. So I'm not dismissing that the brain doesn't have primary pathology, but I'm trying to figure out, is everything secondary to what's happening in the lung? And one thing that I might just say one more thing, that like I've seen so many people with acute hypoxemic, I've rarely seen anyone have choreiform movements after that, which would make me really worried about the brain too, and like something spreading to the brain, just based on that, based on my experience. Now, I may learn later that the guy was hypoxemic, had hypoxic brain injury and had these movements, but I think it's, like based on my experience, more likely to be a both lung and brain process through a single explanation rather than lung, then brain.
Absolutely beautiful, Prof. Rez. Yeah, I'll just share my reflections on that CT scan, which so those of you on YouTube can scroll back to that moment. I didn't see any focality on the CT scan. It's hard for me, having a lot of practice seeing older, smaller brains, to know whether the fact that this brain looked really, really tight, whether that was cerebral edema or whether it's just normal for his age. And I struggle with that a lot. But I think given the clinical context, if I were in isolation by myself, I would at least worry about the possibility of cerebral edema in that patient, which comes in many, many forms. Cerebral edema comes as a result of what's called cytotoxic edema, where the cells are dying and they balloon, or vasogenic edema. And diffuse cerebral edema is often cytotoxic because vasogenic edema is usually focal. from a focal vascular process like a malignant, so on and so forth. So all that I would do without a help from Zakaria or radiology is be like, query diffuse cytotoxic edema. I was staring at the contralateral left cortical space where the seizure might localize from, and I could not find anything myself. What did you think of that CT, Zakaria, or if anybody else wiser than I thought of it?
It's incredible. So this patient, this was actually back at my old hospital where we did have radiologists.
Oh, you did? Oh, lucky me!
And the radiologist said that CT scan was completely normal.
Wow. For his age, yeah.
So onto Aliquot 5. I think, Zakaria, you were sharing your screen, and then when I shared mine, for some reason, yours hasn't yet come back. Yeah. So onto further investigations. For patient Nelson, the 15-year-old with a normal CT brain, he had an LP that showed a mildly low glucose, a marked neutrophilia, and elevated protein. His CSF culture and CSF gram stain were negative, as well as a TB gene expert. And the gram stain on his blood culture was positive. And then for Prof. Reza's patient, I'm going to share my screen to share the video. But as I'm doing that, one thing I wanted to say that was unusual for us with this patient was that X-ray when he'd been admitted was absolutely horrific. And yet his initial blood gas showed quite a normal PO2, even before he'd been intubated. And yet he'd had quite low saturations. And 1 second, I'm just going to share the CT scan 1 week later, where after he'd been extubated and had these abnormal movements. And
Zachary, can you do it one more time for me, please? I mean, this is a 19-year-old patient, right? It just seems like there's too much black space. If I'm not mistaken, it just seems like there's atrophy. Now, I don't often interpret CT scans. What I saw some white stuff more towards the center, but it just the cell size seemed pretty deep. So I don't know, but Zachary, maybe you can teach me. Was it like atrophy? Was it diffuse? It just seemed like really deep sulci there.
So I think what I'll say, and then we can maybe look at this CT scan afterwards. There's probably other abnormalities that I've missed that I think you're picking up on that seem to be abnormal for a 19-year-old. And I'll share my screen at the end. But what I will say is that I think the first thing is I'd like to ask Rabih if he has any prediction of what the gram stain on blood culture showed for the patient that was 15. And then Prof. Reza, I will say that on that CT scan, the patient has a finding that is pathognomonic for a diagnosis that explains everything from the time he arrived at the hospital until he was extubated.
My analysis is so much easier than Prof. Rez. Prof. Rez, I wish you good luck. I hope you navigate your anxiety-provoking question well. Yeah, I think that to go back to the original question, Zachary, what will happen if we transplant this patient's brain? It will not work. When you're thinking about somebody who has a disproportionate encephalopathy, as this patient has, and your radiologist helps you interpret that the CT is negative, essentially it's helpful to think about diffuse encephalopathy in two categories. Is it a parenchymal issue or a meningeal issue? And I think a parenchymal issue here was exonerated by a relatively reassuring CT scan, and you've proven a meningeal issue. And the marked neutrophilia with a low glucose is very, very suggestive of pyogenic bacterial meningitis. And so you're essentially asking me what the base rate of pyogenic bacterial meningitis is in an presumably immunocompetent person. And this is exceedingly rare in many parts of the world because of vaccinations, and the incidence of both streptococcal infections and Neisseria infections is reduced because of vaccinations in those, but those would be overwhelmingly the most likely. And so I think the thing to try to predict is this is a gram-positive organism from Streptococcus pneumoniae, or is this a gram-negative organism, Neisseria meningitidis? And I think based on his age, it becomes an interesting debate. Absent the age, the distance between strep pneumo, which is by far the leading cause, and Neisseria meningitidis is extremely high. Strep pneumo is infinitely more common. And so what happens by factoring in his relatively young age is the distance between those two infections narrows and narrows and narrows and narrows. So at the end of the day, I think to be able to predict this infection with a high degree of fidelity is very, very difficult, which is why you would accept any result the microlab gives you because the range of possibilities is high, but the most common cause, over 80 to 90%, is either strep pneumo or Neisseria meningitidis. And I think based on his age alone, you give more room to Neisseria meningitidis than you would otherwise. And the nature of the gram stain will help you. If it's gram positive, it's very likely to be strep pneumo. If it's gram negative, it would likely be Neisseria meningitidis. And if I had to make an educated guess based on other features that you've shared in this case, I think how abrupt and how hectic this is very characteristic of Neisseria. Most of the time, strep pneumo meningitidis develops over days. There are horrific case reports of patients going from 0 to 100 with Neisseria meningitidis. And so that aspect of 0 to 100 further reduces the distance between those two infections. So I've talked a lot, but I'll summarize. The two most common causes of community-acquired meningitis are strep pneumo, a gram-positive organism, and Neisseria meningitidis. Strep pneumo is much, much more common. Here, Neisseria meningitidis takes up more space in my mind, owing to the patient's youth and the hectic, abrupt, severe nature of the syndrome. On balance, I think it's actually probably 50-50, when it otherwise would be like 80-20. All right, Mike, to you, Prof. Rez.
I actually am using open evidence for this case at this juncture. And what I'm very comfortable with is what's happening in the lungs, because this is something I deal with on a regular basis. It would be fake of me to pretend like I can interpret CT scans or even get upset at missing a prominent abnormality on CT scan. That's not my expertise. I look at one CT every so often. And unless there's like a hemorrhage or a large mass, I'm missing it. To be able to identify structures like the basal ganglia, I can't do that. But what I can do is I know choreiform. I know the basal ganglia is involved in movement disorder, so I can frame the problem. So how did I frame this problem? Young individual with both pleural parenchymal pathology and choreiform movement. If it was just choreiform movement without that pleural parenchymal pathology, then you can say, oh, he had an arrest, he was hypoxemic, that's brain damage. But it's not. You got to explain the lung and the pleura. And I already know the lung and the pleura is inflammation and it's exudate. It has to be infection prioritized in a young person who's immunocompetent. And then if you say, okay, what infections cause pleural parenchymal disease? You can have typical bacteria, for example, Streptococcal pneumoniae, Staph aureus, where you can get a pneumonia and you get a complicated peripneumonic effusion or even an empyema. But I've mentioned this before that I've seen so many patients and none of them with typical bacterial infection of the lung have choreiform movement. So now I have to step back and be like, okay, are there any other infections that have this signature, pleural parenchymal disease, and then this? And this is where I would go back with the patient's family and ask about the time course. Because now I bet you the time course isn't acute for the pleural parenchymal process. I bet you it's subacute. Because when you put this in open evidence, only one infection comes up as the culprit, and that's TB. That's pleural parenchymal TB with TB meningitis involving the basal ganglia. Now, if you take infection off the board, you can imagine if someone had endocarditis and stroke of the basal ganglia, if someone had antiphospholipid syndrome, stroke of the basal ganglia, they had lupus effusion, and then stroke of the basal ganglia. But we have to prioritize infection. We're prioritizing inflammation. It's from the part of the world where TB is 1, 2, and 3. And this is a well-known phenomenon, which I bet Zachariah and his colleagues reflexively said this must be TB based on the chorea form. But how can I do that? Because I'm practicing outside, which I appreciate Zachariah for bringing this case. So this is something in clinical reasoning known as context specificity. When you're practicing within the US, if someone comes in with fever, history of IV drug use, murmur, it's so easy for us to say endocarditis. But go to Japan. Endocarditis for them is a rare phenomenon. They have to activate system 2. So now from this case, with the final thing I will say is this: if you know how to frame, you don't need to necessarily interpret all the CT scans, and you don't necessarily need to be in that area of the world. But you have to be cautious. You have to say, oh, could it be this? And then you talk to someone like Zachariah, who is going to have system 1 thinking in a case like this.
Oh gosh, Prof. Reza, I feel like I have to apologize to you. This patient came in and on the first blood gas actually had the diagnosis, and I have taken you to the end consequences of the disease and made you work back and not giving you some information. And it's fascinating because I really appreciate your humility to say that it's difficult to interpret CT scans and we don't get much exposure. And it's one of my biggest weak points is image interpreting. And what was so funny was I was talking to one of my seniors and I was saying that because we knew what the diagnosis was, I was saying, I remember reading in first aid that this disease classically causes bilateral globus pallidus lesions, but I have no idea really what the globus pallidus is. And that patient, a few hours later, came back from CT scan and had a textbook example of bilateral globus pallidus lesions from carbon monoxide poisoning. And just reflecting back, what confounded this was, even if you hadn't had a blood gas, is the patient had massive aspiration pneumonitis that took quite a while to resolve. Not sure how long it took for him to be found, then brought to the hospital, intubated, and he had a massive aspiration that was the cause of that severe pleural parenchymal disease, as well as him having initially what was a normal PO2. And that was the clue, is that his PO2 was normal, and yet the blood gas is telling you that his oxygen saturations are 70%. And there's a disconnect there. And the reason for that is that the other 35–40% of the SATs that was being measured was from carboxyhemoglobin. And that's why this patient ended up being diagnosed with delayed neuropsychiatric syndrome from carbon monoxide poisoning. And
I actually love that, Zachariah. And the truth is, I mean, this just shows you when you don't know the sequence of events and you don't have the data come in the order you expect it to, it's almost impossible to solve the problem. It like really reminds me of the other case you presented, Zachariah, where you took us straight to the ICU with the echo and the bradycardia and the low EF. That became the center of our focus. And it was very challenging to solve that problem. But if you step back and you saw the sequence of events, it became a simple exercise. And I'm, you know, in a case like this, yeah, I think that if I step back and you presented it differently, I'm not sure I would still get to the diagnosis because I'm not that well versed in carbon monoxide poisoning. But sequence of events matter. You can show all the movement abnormalities. You can show basal ganglia lesions. You can show bad pleural parenchymal disease. But if you don't have the sequence of events, it's likely you're going to end up like what I did, solving the wrong problem.
Amazing. I can't agree more with everything you said. I think then just to end the case off, in terms of patient Nelson, his gram stain on blood culture showed gram-negative cocky, and he was diagnosed with Neisseria meningitis.
It's really, really unfortunate. Gosh, I think what's the theme here, Zachariah, for me? I think the theme here is we're very, very lucky that that both these conditions in many, many parts of the world are mitigated through interventions at the healthcare system level, both carbon monoxide poisoning and Neisseria meningitis. And it's really a privilege to have the opportunity to practice these things in the chaos that they probably happen. I think you're showing us two great examples of horrific parenchymal disease in the basal ganglia and horrific meningeal disease with Neisseria meningitis. And I think ultimately, my reflection on Mr. Nelson is that's just really tragic and really, really unfortunate. I suspect the prognosis for both of them isn't so great. Not to step in on Prof. Rez's toes, but to be honest with you, I have to go to rounds. I just wanted to share a little bit of a knowledge gap that I have on Prof. Rez's case, which is I've always had the working model that a carbon monoxide causes you to SAT 100%, and that diagnosing it is actually really, really difficult because you have a SAT of 100% and a PaO2 that's proportional. So I don't know if you just have a moment to shed light on what even prompted you all to test for carbon monoxide, because my understanding is the SAT should be 100% no matter what in carbon monoxide, and maybe I just have that wrong or whatnot. So I imagine that other people might have had that question too. So maybe you can zoom in on that factoid before I have to go figure out why my patient's bradycardic.
Yeah, I think I could be mistaken here as well, but I tend to confuse methemoglobinemia and carbon monoxide poisoning. And from my understanding, the carbon monoxide binds to oxygen with about 50 times the of oxygen. So what ends up happening is that you have oxyhemoglobin and carboxyhemoglobin sort of competing. And that's why you usually will have normal total saturations, but you have so the oxygen saturation will be relatively low, and then you'll have a high carbon monoxide level, and that's why on the test machine that we have carboxyhemoglobin reported that as well. Yeah,
I see. So you guys are a step ahead of us, because I think it sounds like you reflexively get an ABG with co-oximetry. And just so you're aware of the context that we practice in, Prof. Rez and I, what would happen is this patient would come in and he would be satting on the pulse ox 100%, because the pulse ox does not have the ability to distinguish oxyhemoglobin from carboxyhemoglobin. They look identical. And so someone like me would 100% miss this case in real life, because unless you have reason to suspect the patient has carbon monoxide poisoning, there's nothing that prompts you to order the ABG with co-oximetry. Most ABGs in my institution, I know Prof. Rez is the same, does not give you a free additional co-oximetry unless you specifically ask for it. And even when you ask for it, they often, it's such an underutilized thing that people forget to do it, which actually, the case that I shared with you all in the academy of methemoglobin, I had to beg them to do the co-oximetry. So that's a really, really cool, I just wanted to make sure that the audience knew that you really had to go above and beyond in most institutions to diagnose carbon monoxide. So thank you for clarifying that for me.
Absolutely.
Now that you have me all perspired, sweating, and dazed, I will thank you for the journey, and now I will have to catch my breath to tackle bradycardia. Prof. Rez, do you have a few moments to hang out and end the session?
Yes, I do.
You're the best.
No problem. Take care, Robbie. I did do a YouTube video on this, and this will explain it to you guys perfectly. I spent hours studying carboxyhemoglobin and methemoglobin and the various wavelengths in the pulse ox and why we have the values we have. But if you want to really understand it, just watch that 13-minute video. Zachariah, thank you so much for these two cases. As usual, very complicated, but just full of pathology, full of learning, regardless of like what the outcome was in terms of diagnosis. So I appreciate you, man. Thank you as always.
Can I actually speak about a minute about a couple of things? Just with this patient who had Neisseria meningitis, right? I think it really, really highlights the importance of having certain protocols that you always follow when somebody is ill, and it's something that you always do no matter how tired you are or something, because it's just something that you have to follow a protocol for a patient like this. So this patient was young with all the reserve in the world. So yes, his blood pressures were normal, but he was not perfusing well. Capillary refill was about 4 to 5 seconds. He had lactic acidosis. And immediately when you get the history that he was completely well 24 hours ago, yes, he has no fevers. Yes, there's methadone on his tox screen, but I can't get an LP in the next 6 hours. This patient needs to go for a CT scan. The protocol then is new onset acute neuropsychiatric syndrome, and I can't get all the tests that I need. This patient has meningitis until proven otherwise. You have to do blood culture and start ceftriaxone, and within about an hour of starting ceftriaxone, you actually clear the Neisseria from the CSF. So there's a dramatic improvement as soon as you start those antibiotics. And I think this patient, if he hadn't had as much reserve, hadn't been as young, was going to head into DIC and septic shock probably within hours. Yeah, so I think that's just really, really important to always follow and try and do the right thing. Yeah.
Beautiful. Thank you for that. That's really, really important. Harry, it's your time to shine.
Yeah, what a wild cases, I should say. So I got a little distracted, got a call from a resident in the middle of it, but so I might miss something, so please fill in any gaps. But we talked about altered mental status, especially in acute altered mental status in a young, otherwise healthy patient. Don't forget about our mnemonic, but also including primary psych disorders, especially in this age group, versus neurologic and medical causes like toxins, metabolic arrangements. And Robbie talked a bit about finding a company that altered mental status keeps. Talk about bilateral constricted pupils, usually think about it as bilateral parasympathetic excess, which is more common, or sympathetic loss. And just remember, bilateral corners is rare. Differential includes increased intracranial pressure, commonly opioid overdoses, cholinergic toxicities. Try to identify localizing symptoms and focal lesions such as a seizure, focal seizure. Talked a little bit about chorea, the dancing-like movements that we saw, typically localized into basal ganglia, like in this case, but can be related to some systemic diseases like Huntington's, medications, of course, as well as symptoms chorea from group A strep or rheumatic fever. We also talked about how in young healthy patients with hypoxic respiratory failure and inflammation, think about infection over cardiac, but don't forget blood as well. And a unifying pleural parenchymal infection in chorea includes pulmonary TB with basal ganglia involvement. And then we talked about pyogenic bacterial meningitis for Nelson. Talked about the findings: low glucose, neutrophilia, and high protein on LP. Most common organisms are strep pneumo, Neisseria meningitis, and young patients without vaccines strongly consider Neisseria. And then, of course, we talk about carbon monoxide poisoning with our patient Desmond. Remember, our ABG, our routine ABG will show normal PaO2, but because of impaired oxygen binding, there will be hypoxic injury, and so you need a co-oximetry with the ABG to diagnose it. In this case, we had hypoxic injury with basal ganglia injury leading to chorea for Desmond. And that's all I have.
Well, Harry, that's incredible, my friend. Where are you located?
I'm in San Francisco General.
Oh, fantastic. Well, thank you so much for hanging out and teaching. Thanks both Zachariah and Robbie. Hope you all have a great day.